Hi everybody, welcome. We're getting ready to start. We have a smaller crowd than anticipated. I know over 46 signed up, but I heard parking is a challenge in the neighborhood. So I hope that didn't deter people from coming in. So as I said, welcome. Before we start this event, it's really important to ground it in a territorial acknowledgement of where we stand and where we are. So I'm going to turn it over to our Dean and Rector of this cathedral, the Most Reverend Dean, or Tim Dobin. Okay.
Well, good afternoon everyone, and on behalf of Bishop Susan, our corporation and ministry team, a warm welcome to our beloved cathedral. We see what's happening this afternoon as a significant contribution that we make here to the health and well-being of our city. We love to gather folk and provide space for conversation on significant issues that impact our lives, and especially the lives of those who are vulnerable. Very grateful to Kerry Lubrick and members of our community engagement team for their vision, initiative and hard work in terms of assembling us this afternoon. Well done. This learning opportunity is also taking place during Pride Month. We are a community who seek to welcome all people without exception, because we believe that every person is a beloved child of God. So as Kerry has mentioned, we also recall that for those of us who are non-Indigenous, we're settlers and gatherers on this land. The city of Hamilton is situated upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee and Mississaugas. This land is covered by the Dish with One Spoon Wampum Belt Covenant, which was an agreement between the Haudenosaunee and Anishinaabe to share and care for the resources around the Great Lakes. We further acknowledge that this land is covered by the Between the Lakes Purchase of 1792 between the Crown and the Mississaugas of the First Credit Nation, Treaty 3. We also share a more painful inheritance, our complicity in colonial systems that harmed Indigenous peoples, cultures and spiritual traditions. As churches, we're called to share the truth about our shared past and to walk humbly in the ongoing work of healing and right relations. For more than 3 decades, the Anglican Church of Canada has been on a journey of listening, truth-telling, repentance and healing with Indigenous peoples, both within and outside the church. We acknowledge that there's urgent need for further healing and justice seeking across the land. And we all have a role to play to learn about the rich history of this land so that we can better understand our roles as residents, neighbours, partners and caretakers. To acknowledge these lands is to take one step in demonstrating our commitment to dismantling the ongoing legacies of settler colonialism. May we bring that same commitment and spirit of truth-seeking and reconciliation to our conversation today.
Thank you, Tim. Much appreciated. So, as Tim identified, my name is Kerry Lubrick, and I'm a volunteer and the chair of our Community Engagement Committee here at Christ Church Cathedral. So welcome to our beautiful cathedral. We find this space is a multi-use space. It's about really offering town hall and information besides worship. A little bit about the church, just so you know, a little history. It was actually established in 1835, and the original building was the same architect who designed Dundurn Castle. And then this building, as you see it now, was designed later and built in stages. So from 1952 to 1852 to 1873. Listen, if you want information and you want to see this place in beauty, come tomorrow night during Art Crawl. Our doors are open and this place is welcome to everybody. Also during Super Crawl. Tim already mentioned the Community Engagement Committee is hosting this event, and what we are is really setting a strategic direction on where we need to go as a parish and act on social justice issues with love, dignity, and reconciliation. So we act and we build on relationships with our neighbor. Doesn't matter who our neighbor is, whether it's a business, whether it's a tenant, whether it's a homeowner, or it's somebody sleeping rough. So we saw an increase, or saw some of the concerns with addictions in our neighborhood, and we thought, you know, this is the time to have an educational event. We did have a session a couple of years ago on mental health, and really mental health and addictions are tied very closely. That session we did was with Canadian Mental Health, and they're at the back there today, so thanks for being here, Jill. Also, you probably know Cathedral is is in partnership with St. Matt's, and we host the Cathedral Cafe. The cafe is open Monday through Saturday from 9 to 4. It's a place for people that are homeless or precariously housed to come, and they receive support on what they need, when they need it, and how they need it. They tell us what they need. So addiction support is one of the services that is offered here. And breakfast and lunch is served daily because, of course, food insecurity is a huge issue. So we do have 7 information booths at the back, and I thank you so much for being here, sharing your time. So we have Canadian Mental Health, the Metis Nation, St. Matt's, Paramedics, Positive Health Network. We also have Public Health, Harm Reduction, and Paramedics, and Urban Core. So thank you everybody for being here. Bit of housekeeping, refreshments are at the back. Get up anytime you want. There's coffee, tea, water, and some treats, so thank you for that. If you need to use the washroom, please see one of the greeters at the back and they will direct you. This event is being live streamed. We decided that last minute because a few people wanted to be connected through live streaming, and it will be recorded. For those of you that do not want to be in the camera, no worries. It's just this team that is going to be on the camera. The camera is getting the back of your heads, not your faces. So if you don't want to be in camera, you know, you don't have to worry. I just want to talk about a safe space. This is a safe space for everybody. Please refrain from any disrespectful language or comments. We don't have to agree with everything that is being said today, but please listen carefully and be respectful. We do have 4 objectives that we'd like to achieve. First of all, understanding what's happening with addictions here in Hamilton and even in our province and what's happening on the street. Secondly, we want to receive some basic information about addictions, what it is. Third, we want to learn about harm reduction and the addiction services that are available in our community to all. And finally, and this is an important one, everybody came here to learn. I hope we could walk away with some actions, tangible actions that we could take as neighbors, residents of our community. So that being said, that's our agenda for today, and we're going to start off with our panelists. So I'm going to just ask you to stand as I introduce you. So first of all, we have Ray Bryant, and he's the manager of harm reduction programs and services at Positive Health Network. Ray has worked for over 20 years with marginalized members of the community, and he's worked extensively with people who use drugs, focusing on people who are unhoused and are at risk of homelessness, and those that are at risk of acquiring HIV or hepatitis C. Through a harm reductions lens, Ray promotes safer practices and prevention strategies through collaboration with many community partners across the region of Hamilton, Halton, Alderman, Norfolk, and Brant. Thank you, Ray, for being here. Next, we have Jim Clayton, actually Sergeant J. Okay, I want it to be official, with the Hamilton Police, surprise. Jim has 16 years with the Hamilton Police Services. His work includes action, uniform coal patrol, heat, high enforcement action team, plainclothes proactive investigation, biker enhancement unit, working with the OPP and other contributing services with a focus on outlawed motorcycle gangs, and sergeant of major projects in intelligence, so organized crime. As of the fall of 2024, so almost a year, sergeant in charge of the crisis response branch. Jim's current portfolio includes the Mobile Crisis Rapid Response Team, COAST, the Social Navigator Program, and the Encampment Engagement Team. So again, thank you, Jim. Next, we have Tiffany. And Tiffany is the manager of substance use and health at Hamilton Urban Core Community Health Center. Tiffany works centers on improving the well-being of the most vulnerable in our community who face multiple interacting challenges to their health. Currently, Tiffany is developing the mental health and addictions treatment, MHAT, is that how you're pronouncing it? Provincially, so you've heard about HEART. This is Hamilton's version of a HEART. They've added the M. Hub program, increasing capacity to serve community members experiencing mental health concerns and addictions. Tiffany brings to her role in leadership, being in her role in leadership for over a decade of experience working in healthcare across multiple settings as a registered nurse. She is honored by the invitation to speak with the panel today. So thank you so much, Tiffany. So next we have Susan Boyd, and Susan is the manager of alcohol, drugs, and gambling services and the mental health outreach team with Healthy and Safe Community Department of the City of Hamilton. Susan has a master's in social work and has worked in areas of mental health, addiction, and homelessness for the past 30 years. Susan has worked directly with individuals promoting social work services both in an outreach capacity and a clinical setting. For the past 14 years, Susan has been involved in management and clinical supervision. So thank you, Susan. Next, we have Catherine McCarran, and Catherine is she's got a long title, so this goes to show how committed these people are. But Catherine is the manager of RAM, which is the Rapid Access Addiction Medicine Clinic, Men's Addiction Services of Hamilton, MASH, Womankind, the Substance Use Service Peer Support Provider Team, and the Capacity Building Team. That's a lot. Catherine is a registered social worker, and she's also the manager of Community Psychiatry Clinic at St. Joseph's Healthcare in Hamilton, West 5th Campus, which is the home to the following programs: Bridge to Recovery, Concurrent Disorders, Outpatient, Youth, Adult Substance Use Program, Borderline Personality Disorder Services, and General Psychiatry. As a manager, she's committed to enhancing patient care from a patient-centered approach. In addition, Catherine has close to 20 years experience working in mental health and addictions, both in the community and hospital settings within Halderman, Norfolk County, and Hamilton, specifically working with individuals with severe and persistent mental health illness and substance use, and highly complex individuals. Thank you. Amazing. Yeah. And then finally, we've got Cheryl Lynn Penner Cloutier, Manager of the Mental Wellbeing, Substance Use, Public Health Services, Epidemiology and Wellness Division with the City of Hamilton. Cheryl Lynn is a graduate of McMaster School of Nursing in 2003, a registered nurse and a graduate of Waterloo University Health Sciences. She has a long history of exploring health health of individuals and population. Cheryl Lynn started her career as a public health nurse in the sexual health program in 2003, has worked for the Hamilton Public Health Services since that time in a variety of roles, including frontline sexual health, harm reduction nursing, providing nursing leadership during COVID pandemic. In her time at public health, Cheryl Lynn has seen devastating impact of the substance use on the population, on the community, and on individuals and their families and friends. Her current work provides her the opportunity to collaborate with community health and social services to work towards the prevention of substance use, attending to the needs of those engaged in substance use, and supporting access to treatment. Much of this work happens through the Hamilton Drug Strategy and its associated work groups. So thank you. So as you could hear and see, what a team of experts we have here. We are so excited to have you. So we're going to now move along because I'm going to ask Cheryl Lynn to talk about what's happening with addictions and the opioid crisis. So I'll pull up your slides and we'll take it over to you.
Carrie, do you want us to come stand up there?
You could sit right there. Whoops, sorry. Yeah, we'll do it.
What you see on the slide right now is just stats that we are seeing on tobacco are getting better, but it's been a very long process to get there to really, and it is a substance that is addictive as well, but the nicotine specifically, so something that we do want to recognize. I'm not going to go deeply into tobacco. We do have another program that is in public health that is specifically geared to tobacco, but I just really wanted to put this into context for all of you today as well. Hamilton still experiences opiate-related harms at higher provincial rates. So we see in Hamilton our rates of death are above that of what is the province. And so so it is certainly a problem or a concern that really impacts Hamiltonians and something that really deserves our attention. And one more recently, we've noticed the research and the data that's coming out about polysubstance use. So there are a couple of instances that can cause polysubstance use when you have unregulated drugs. They can be contaminated with other substances that then change what that drug poisoning looks like and how it responds to the intervention. But also have to recognize as well that oftentimes people may be using substances purposefully, where they're using both things like alcohol and other substances at the same time. We also want to recognize as well that folks experiencing material marginalization often bear the largest burden related to substance use. All right, so moving on to the next slide. I do have information about cannabis, but I'm not going to really touch on it because I think it's just really, I want to do a little bit of focus on alcohol and then a larger focus on opioids. From the Community Health Status Report, we are able to look at alcohol consumption rates. And what we can see is that approximately a third of Hamiltonians exceeded low-risk drinking guidelines in the past week, so within a week's time. And then the percentage of Hamiltonians that did not drink, so were abstinent from drinking at all in the past week has decreased. So we're seeing that more people are drinking more regularly. And a third, and also noting too, that a third of Hamilton secondary students drank in the past month. So we're seeing that definitely students are and youth are participating in consuming alcohol. And then we're going to talk just a little bit about alcohol harms. And this is again, although alcohol is widely considered to be socially acceptable substance, legal substance, it is important to recognize the harms and costs that are associated with alcohol consumption. In an average year, it is estimated that alcohol causes 280 deaths, 1,073 hospitalizations, and 9,123 emergency department visits among Hamilton residents. In Ontario, alcohol-related harms related to health, loss, productivity, criminal justice cost more than any other substance. It is important to acknowledge that although alcohol consumption is legal, it does not mean that it is safe, and individuals that are consuming alcohol should be aware of the risks and harms when making the decision to consume. Canada's Guidance on Alcohol and Health that was released by the Canadian Centre on Substance Use and Addiction in January of 2023 clearly states that overwhelming evidence confirms that less consumption of alcohol means less risk of harm. All right, so great pages here. All right, so let's move on to looking specifically at opioids. And this will do a little bit deeper dive. Again, a lot of this information is in our community health status report, but I do have some updated data because opioids is something that we do monitor quite regularly and the impacts of opioids as well. So it also is important to recognize when we talk about opioids, sometimes we are lumping them in also with any unregulated substance. So that also includes things like methamphetamine and cocaine, which are substances that are also have a significant impact. But what we tend to measure a little bit more is opioids and the impact of opioids. So I just want to recognize that there are other substances that are unregulated that do cause concern as well. So what we can see is that over the course of the opioid crisis, fentanyl has become the most dominant substance. Fentanyl are some key messages on the slide about the harms from the Community Health Status Report. But again, like I said, we'll have a little bit more recent data that's coming afterwards. So the rates of morbidity and mortality in Hamilton related to opioids are, as I mentioned before, significantly higher than provincial rates. Harms are concentrated generally among males ages 25 to 64, and people who are unhoused are particularly vulnerable to substance use harms. In terms of emergency department visits related to toxicity, or what we'll call drug poisoning or overdose, the largest percentage consistent is across all age and sex groups are related to opioids. Opioid-related deaths have increased substantially since 2016, where we started to really recognize that there was an opioid crisis looming. And they do remain very high overall. This is okay, all right, okay. Sorry, I lost my place there. Opioids and an increasing toxic drug supply has been an area of public health concern in Hamilton. In Hamilton, we started to see an increase in deaths in 2017 attributed to opioids, and locally, we continue to see a sustained impact on our community. All right, so now into just a little bit more specific data. I think we're just going to give you raw numbers in terms of our opioid toxicity deaths. And part of this is just to kind of look at that trend over time. What we have seen is, particularly during the COVID pandemic, the impact of opioids was even more significant. What we've seen in the past 2 years is just a little bit of a decreasing, but we're still leveling off at very high levels of opioid-related deaths. So since 2005, opioid-related deaths have increased by 446% at a rate consistently higher than the province of Ontario. I think that that's probably the key point related to this slide as well. And then we'll move to the next one, actually, where we change those numbers into rates, which makes it a little bit easier to compare to what's happening in the province. So as you can see, and also trends as well, where rates is really about a proportion of the population. Trends in the rates of opioid toxicity deaths among Hamiltons over time are similar to trends in the counts of deaths. And the rates of opioid toxicity-related deaths among Hamiltonians was highest on record from the past 3 years, and still are consistently higher than the rates in Ontario. We do get, thanks to our paramedics, we do get some information about drug poisoning calls in Hamilton. And so again, we're seeing some of the similar ideas where we did see a great rise that was happening since 2017. And as of, we had a peak in 2023. In 2024, we started to see a little bit of a trend towards a decline, and which then followed through, and I'll show you on the next slide as well, followed through into the first quarter of 2025. However, since March the 31st, we are starting to see those rates climb again in terms of calls to paramedics. So I think this is my last slide. While indicators of opioid-related harms and deaths often trend in similar directions, what you can see on this slide is where you have suspect drug-related deaths, paramedic calls, emergency department visits, opioid-related deaths, and then also hospitalizations as well. And as you can see, for Q2 of 2025, we are seeing that start to rise again in EMS calls related to drug toxicity events. I think I'll leave it there.
Okay.
And I will pass it off before I lose everyone in stats.
Well, thank you so much, Sherilyn, for that overview, because it's really important to know what we're looking at, what you're seeing from all of the statistics. So to make sure we all know what we're talking about here, I thought it would be really important to talk about what is addictions. And I know, Sherilyn, you covered a bit of it, you know, who you're seeing, but I'm going to turn it over now to Catherine Susan and Tiffany to talk about what is addiction. So if you could share the mic, it's live, so you're ready to go. Whoever wants to start.
Okay, good afternoon, everyone. So we will go back and forth to sort of answer this question that Karen's put out. And so often if you would Google and look up a definition for addiction, you will see different ways that it's explained, but there are always some key kind of components of looking at an addiction. And you also will hear about different terms. So sometimes it'll be referred to as an addiction, a substance use disorder, a substance use problem. And so sort of a straightforward way of looking at an addiction is it's when substance use has become problematic for an individual that's using. And so when we talk about problematic, part of it is what do we mean when we say problematic? And so there is something, again, that kind of helps with the definition, which is known as the 4 C's. And so the 4 C's looks at when there's a presence, when somebody's using, it could be alcohol or drugs, that they've lost some control. So it can be because they can look at the frequency that they're using or the amount they're using. So it could be somebody sort of says, hey, I'm going to use once a week, and they find themselves using 3 times a week. It could be they say, I'm going to have a couple of drinks, which is going to use a little bit, and they find they've exceeded those sort of limits they set for themselves. That could be a beginning of looking at like they're losing control of their substance use. One of the other C's is cravings, and so cravings can be either thoughts or feelings, and so what people will find is that they're thinking about substances a bit more than they were before. And then they're struggling sometimes with, they kind of say, hey, you know what, I don't want to use today. But the thoughts are there, the feelings are there, and it becomes harder to not sort of follow through on those. And that's one of the other C's is compulsion. And so compulsion is when you're kind of drawn to something. So for a lot of individuals, if you've ever experienced anxiety, anxiety is kind of this push away from something, where addictions can be this pull towards. And even though people have sort of, like I said, they've set some limits. And then the last C that talks about when something's potentially becoming addiction is consequences. And so what can happen over time is that people start to experiencing consequences that they would see as harmful or they're getting in the way of the rest of their life. And so consequences come in lots of different ways, and they're very different for different people. But it's when people start to realize that, hey, you know what, this is actually getting in the way of what I'm trying to do with life. And so that's a very sort of straightforward sort of look at what an addiction can be. And so, oh, okay. My partner said it was quite comprehensive. So maybe the other thing we could look at is sometimes what happens is people have difficulty understanding, you know, why does somebody develop an addiction and somebody else doesn't develop an addiction, and though it seems like they're going through the same things. And so there are different things that contribute to an addiction, and we do know that substances in particular, like they affect our brain, they affect our body, and it can affect everybody differently. Because sometimes if you think about medication, you might take medication, your neighbor takes medication, you end up with some kind of contraindication, and the other person does fine. And so substances can be the same way in that they impact people differently. The other thing that can contribute to addictions are things like stressors. So when we think about life unfortunately, especially right now, is full of a lot of stressors. But stressors can be things like if somebody is dealing with grief and loss, if somebody's dealing with housing insecurity, income insecurity, then sometimes because substances have this immediate impact for a lot of people, it becomes a way to cope with what's kind of going on in their life. Other things that can impact an addiction to or contribute is things like availability and access. So it depends on what our policies are around substances. That can really
Well, thank you so much for that overview, and that really helps put it in perspective because, as you said, it's not one straight line. It affects everybody. It's, that's what makes us all interesting as humans. What works for one doesn't work for another. So thank you for that clarity. So at this point, we're going to turn it over to each of you to give a quick presentation on what your organization does. Like, I know police, but it's specific to yeah, not everything. And same with St. Joe's. We know St. Joe's covers so much, but specifically in your area of responsibility and how it relates to today's discussion. Now, because I'm conscious of time, and especially Tiffany, I'm going to start with Tiffany and work our way back so you could run to your meeting, okay? So I'll turn it over to Tiffany to talk about urban core. Yeah.
Thank you. Apologies, folks. I do need to step out at about 2:25, but I will be coming back for an emergency meeting. Hamilton Urban Core's Mental Health and Addictions Treatment Hub. Our work is centered on a population of 18 plus. So if we do receive somebody that's under that age, we would be making an external referral to an appropriate service. We're provincially funded for folks 18 plus who are suffering from mental health and or addictions concerns. We understand that they overlap, and it's often what came first, the chicken or the egg, as they both are interacting. So we provide a whole host of supports. We are ramping up and building this program from the bottom up. So we started off with increasing our free shower and laundry services and adding on a daily lunch program. However, with the understanding that if somebody comes to us and they're hungry in the morning, we're going to find food for them. If they come to us with no shoes, we're going to find shoes for them. So it's really in the same spirit of wraparound service that we had over the consumption and treatment service. It's a completely different service. It is not one to replace the other. It's what is now provincially funded as the province is moving in a different direction from harm reduction more to an abstinence-based recovery model. And we know that we're going to be able to help a lot of folks within that model. So we are currently adding on to our programming. We're adding cultural elements to make sure that we're providing culturally affirming care. We have our Indigenous cultural programming that's beginning in 2 weeks, centered on grandfather teachings and traditional activities. We just welcomed a Black Health Community Cultural Ambassador who's going to be ensuring that we're accessing the segment of our population that's having multiple interacting factors and intersectionality added onto the challenges of mental health and addictions. We have addictions programming that's going to be beginning within the next 2 weeks, centering on helping folks move through the stages of change. So our program is modeled after the stages of change. And when we have people that are coming to us that are not yet thinking about their substance use, or they're kind of thinking about it, but they're not really ready to make any change or take any steps or prepare to make change, the program is going to be centered on educating folks and helping them relate that knowledge to themselves so that hopefully they can start thinking about their substance use, and if they want to make changes with regards to that, we support them either way. When we find that people are not ready to move through the recovery process, there's still the option to provide harm reduction services. While we can't do that within our provincially funded HEART program, we have and have always had harm reduction services offered through Hamilton Urban Core, as well as through our community partners. So we'll ensure that no matter who is coming to us and for what reason and for what they want to work on, we're going to ensure that they get the service that they need. Thank you.
Thanks. Okay, so we'll turn it over to Ray. I'll get up your slides, I hope.
Hello? Yes, this works. Thank you.
Hold on. Sorry.
That's okay. Once again, I'm Ray Bryan. I'm here today from the Positive Health Network. My colleagues, Sam and Jen, are in the back at the table back there. If you have any questions after this, feel free to stop by and see them. Positive Health Network serves Hamilton, Halton, Haldimand, Norfolk, and Brant. We have a huge geographical catchment area. We have staff in all of those regions, and we provide service in each of those places. As manager of harm reduction programs and services, the approach of the organization with regard to harm reduction is it's an evidence-based, client-centered approach that seeks to reduce the health and social harms that are associated with substance use without necessarily requiring people who use substances to stop or abstain. We know that substance use often occurs in the absence of a medical condition or disorder by choice, and we never, through the course of our work, we never assume that someone accessing our services is addicted. And some of my learned friends here have, made some of those distinctions between the term addiction and substance use disorder. And even to add to that, then there are people who choose to use substances that have neither an addiction or a disorder of any kind. So we also serve those folks. Essential to our harm reduction approach is that it provides people with who use substances with a choice of how they will minimize the harms through non-judgmental and non-coercive strategies intended to enhance skills and knowledge to help them live safer and healthier lives, whatever they choose. At the same time, this approach provides an option for users to engage with peers, medical and social services, and in a non-judgmental way, and we will literally meet them where they're at. Pardon me. We operate van services. I work in cooperation with Public Health, Hamilton Public Health, in the operation of what's lovingly known as the van, a van service that provides harm reduction supplies and support for folks in the evening hours, 7 days a week. And also Positive Health Network also operates 2 vans in Halden and Norfolk Brant regions. And we own and operate those vehicles, and we normally during the day we provide the same type of service out in the Halden and Norfolk Brant regions. So we'll go out to meet people literally where they are. We'll provide them with whatever harm reduction supplies they need, but also through conversations with those folks, we'll identify other needs and make referrals, provide information, education on a number of different subjects that may be helpful for them and may also be unrelated to their substance use. I want to talk a moment about peers. We like to rely on peers to work with our population, and one of the things that peers can do is peers can demonstrate understanding and validate feelings and support in a non-judgmental way that is based on their own personal experience, and in a way that perhaps people without that lived experience cannot. Lived experience allows for a destigmatized approaches and leverages the shared knowledge between the peer and the service user. The main principles that I operate by is that everyone has value and that people have a right to self-determination. Obviously our clients also have the right to confidential, anonymous, and respectful service. And we try to deliver our services in the least intrusive manner and to try and meet the client's needs. One of the things that we are heavily involved in is the distribution of naloxone and also education for overdose prevention. It's one of the things that we stress in the work that we do, and it occupies quite a bit of our time, the folks that are out there doing the frontline work. I echo what some of my colleagues have talked about in terms of there are other substances that we also need to be concerned about, other than opiates, but certainly the opioid crisis is not going away yet. So we need to continue to work, and that's what we're dedicated to. So, thank you.
Okay. Thanks so much, Ray. So we'll turn it over to Jim now.
And Carrie, I think I have to correct you. You said the panel was full of educated and experienced people, but I think there's a bunch of educated and experienced people and a cop sitting at this table. So here we are. I think the interactions that the Hamilton Police Service members have with people in the community is vast. But when it pertains to addictions, I think I found myself in a unique position, just as you alluded to, Carrie, in the intro, being involved in proactive investigations, being involved in drug-type work and projects and intelligence and all those things. I get to see the backgrounds and the backdrop of what that looks like. So I get to see the organized crime members and what they do and how drugs hit the street. Now, fast forward 15-ish years later, I'm given the opportunity by Superintendent Dave Hennick, who leads our community mobilization branch. And he said, Jim, I want you to come over and run our crisis response branch team, which involves MCERT, COAST, SMP, our risk members, a lot of great people. I sit behind a desk most days, but they're the ones on the road trying to help individuals in the community, both with mental health, primarily with mental health, but our social navigator program, that includes our paramedic friends who are all in the same building. We have great partners in St. Joe's, and I've had a chance lately to work with Catherine at the RAM Clinic, helping people with addictions and mental health. And it's, we have our encampment team as well out of the CRB, but all of those things overlie. So I got the great opportunity to just be the new guy and observe. And just like the slides that you showed about the alcohol, and the tobacco, and the opioids, I held a bias that when she started talking about that slide, I was sure that the opioids would be at the top of that list. So I work on trying to educate myself and listen to stakeholders, listen to our civilian partners, and not rely on things that I think I know, but try to kind of erase that bias and learn from people and engage stakeholders to work together, because I see it every day. That our risk members, that include addictions counselors, concurrent disorder navigator, Indigenous navigators, women's navigators, Aboriginal or Indigenous navigators, women's Indigenous navigator with a focus on human trafficking. All of these great people working together and learning from each other and breaking down barriers is huge for solving a problem like addictions. So again, my background and then leading, I think this is why I'm here. Superintendent Henk gave me the opportunity to say, Jim, we need to be in compliance with Bill C-5. Now you ask, what's Bill C-5? It's a directive from the feds that tells us that we need to provide referral services to the people in this community, because we need to start treating possession of a controlled substance, and namely an issue that's arisen over the last few years is open public drug use in the community. We have to tend to that issue, and we have to make sure that they have a place to go or be referred to get the help they need. Because historically across Ontario, apart from Peterborough in the middle of last year, there weren't many other police services that were doing that. Peterborough's pretty, progressive. They have a problem in their community, and they have strong leadership in addressing that type of issue. And we were right behind them trying, and thank God for our strong relationship with St. Joe's historically and the crisis response branch, because we were able to reach across the aisle and say, hi, RAM Clinic, can you help take referrals when we start to interject and people openly using in the public? So that's what we started to do. We started to engage public health, engage the Public Prosecution Service of Canada, engage stakeholders that know more than us. Even though we do know enforcement, we know what the criminal code says, but getting back to interjecting and being that tip of the spear of people openly using in public, and not criminalizing it. There may be people who lose liberties in the process for a very short period of time, but addressing it, ensuring that it stops so that other people can enjoy their parks or enjoy the downtown core area, but come from a health-centered approach. so that we can give them that resource to get help if they so choose. And it's not a quick pro quo. This is not a diversion. This is us being informative, providing them with information, and then me sending that information over to Catherine, just giving them the opportunity to get help. So I think that's what we're trying to be better at, is about introducing ourselves back into the community, not driving by open public drug use, intervening and making sure they have a space to go, and even informing them if there's a dire need. I'm thankful to have like social navigator resources at my disposal to send to that person. And the last thing I will say is that timely intervention is extremely important. Again, we all hold biases about the opioid thing, and I held some biases when it came to this, but the more stakeholders that I talk to, the more people that I work with, those biases start to kind of slowly fade into the background, into the distance. And I think coming from that health-centered approach is so important to give people the help they need. Thank you.
Thanks so much, Jim. Great. So we'll go on to Susan to talk about ADGS, getting my, and your outreach. Okay.
Okay, thank you, Carrie. So I'm the manager of the Alcohol, Drug, Gambling Services and the Mental Health Industry Outreach Program, which are two separate teams, but managed by myself within Public Health City of Hamilton. So to start with ADGS, it was interesting when I was thinking about coming this afternoon. I realized our program is either in its 40th year or next year it's heading into its 40th year, so we've had lots of time to provide service to the Hamilton community. And so Alcohol, Drug, Gambling Services, our name is fairly clear, so we provide help to people who have issues with alcohol, drugs, or gambling concerns. So we provide service to individuals who are 21 years and up for our substance use programming, and that's because we have a great program in Hamilton called Alternatives for Youth. And Alternatives for Youth, we have a crossover age, so Alternatives for Youth will go up to 25. And then our chronic gambling program provides service from 12 years and older. And so what our service does, we have a harm reduction philosophy to our service, so people can come in who are looking at wanting to sort of use safer, want to use in a different way, who want to maybe decrease some use on some substance, maybe not on the other one. But we also, within our umbrella of harm reduction, we include abstinence. So also if people are looking at wanting to stop a substance, they can also come in and see us as well. And so we have different ways that we provide service. So we have a clinic, which is 2100 Street East. So if anybody's familiar, it's right across from the GO station downtown, the little red brick building. We're on the 3rd floor there. And then the other way we provide our service is that we have what we call off-site or partnership services. And that's where our staff are located at that service. For example, we are in with HHSC at the General and Jurabinsky. And part of that is so that individuals don't have to come to us. We're where people are. And the other piece we also offer is outreach services. So where we're going out to people, like one of my staff was here today, who's in very many different locations providing that service as well. And so part of what we do is we'll do intake and information. So if people have a question about addictions, they want to find out about services, you can call. Most of it is by phone. We do have drop-in Thursday mornings from 9:30 to 11:30 where people can just drop in. And so through that intake, we can figure out, is our service the person is
Thanks so much, Susan. So we're going to turn it over to Catherine and Karen now to talk about all of those great programs you're involved with.
I'm going to try, but I don't think 5 minutes is going to be enough. Okay, so the RAM Clinic stands for Rapid Access Addiction Medicine Clinic. It's located across from Charlton, St. Joe's Charlton site. We have a team of physicians, nurse practitioner, and clinicians, substance addiction counselors, peer support providers, nurses, and then also occasionally we can bring in social work or additional clinicians from other programs at St. Joe's, because the great thing about having all these programs under one service, one umbrella, that the teams work fantastic together to really try to link individuals as to where they need to go and try to streamline the process as quickly and as seamlessly as possible. We also have the Concurrent Disorders Capacity Building Team, also known as the CAP team. They're located in the emergency department, also in the medical units, acute mental health units down at Charlton, and also at West Fifth. So it's a consultation team, social work, nursing, addiction specialists as well, and they support patients that are actually in the emergency department, psych emerge on medical units, and in the mental health units as well within St. Joe's. So again, trying to link them while they're in hospital to community programs, whether it's within their home community, within St. Joe's, and working with the teams that are providing care and treatment to them to really have a better understanding and support the patients as to where they're at, whether they want to support abstinence or harm reduction, and really fostering that capacity is being built like staff to staff. So our overall team has a better understanding of how do we work with patients that have substance use and be patient-centered focused, and also from an evidence-based treatment and perspective. The Concurrent Disorders Outpatient Team, it's a team of clinicians. We also are very grateful to have an amazing psychiatrist on the team as well, who specializes with addiction medicine. We support patients that are being discharged from inpatient stays at St. Joe's. We also see patients that are being referred from the community. Self-referrals are always welcome as well. The initial process is meeting with a counselor, doing an assessment, probably very similar to ADGAS, and then really seeing where they're at, what they want to engage with, what they're willing to engage with at that time, and then link them to the appropriate level of service and care. We have a tremendous amount of groups that are available on a drop-in basis. So if somebody wanted to start a DBT informed skills-based group, they can start it as early as basically a day or 2 days later, because we offer, like, for example, on Mondays, Wednesdays, and Thursdays. So we give these resources to patients to really start that engagement as soon as possible. And we also, again, have that cross-clinic, cross-clinician responsibility. So you might see the clinician that you saw at RAM facilitating a group on Thursday afternoon with the clinician that you're working with at Concurrent Outpatient. Again, that wraparound approach and also that warm handover too is really important, because we'll say, oh, hey Joe, we saw you last week, or Joe says, hey Catherine, how's it going? Haven't seen you in a while. And it's really fostering that warm, welcoming environment. There is no judgment here. We're here to support you and move forward with what goals you want to work with. We also, a new project, a pilot program, actually is funded through Health Canada. It's the Substance Use Service Peer Support Program. So it's run with a team of peers, and they work in collaboration with our substance use service team of physicians. And they're supporting patients that are on the inpatient medical units of Charlton, and we're looking to expand into HHS as well over the next 6 months or so. So very excited to continue with that pilot, because what we find is that patients that struggle with substance use addiction, they're more likely to leave against medical advice or leave because of potential negative experience within the healthcare system. Not specific to St. Joe's, but just the healthcare system as a whole. So there's a lot of stigma attached to it. Sometimes there's mistreatment, or they get frustrated and say, okay, I
Well, you did very well to go through all of that, Catherine. So it's just amazing to hear everything that's already going on. I'm making lots of notes because it is about collaboration. It's about meeting people where they are and identifying what their needs are. So finally, do you want me to pull up your slideshow? Sure.
I'm going to take a cue from my colleagues here and try to bring it home.
Okay, okay.
And just also being aware of the time too, because we probably have some questions. As I mentioned before, I work for public health services. Public health generally looks at the population health level, and unlike the colleagues that really do a lot of individual-based treatment and that sort of thing, and Susan would be program being a little bit outside of that normal. Public health, we are guided by the Ontario Public Health
That's awesome. Thank you so much. So this is the point at the agenda that I'm going to moderate some questions that I put together, and then it's going to be your turn to ask some questions to the panel. Tiffany, I see, is picking up her purse. She's got to go, so she will be back. But if we have any questions directly related to Urban Core, we'll hold on for her. She promised to come back. Okay, thank you. So we'll start with, you know, it ties into what you were just talking about, Cheryl Lynn, is about, we've seen, you know, about education and whatnot. We've heard that addictions could, and well, nobody said it specifically, but we've heard it's higher in a homeless population. Addictions are. So what can be implemented to assist the homeless population? Is there any other strategies or things that are working on or that we could look at? And I'm going to throw it out. I think some of you have already touched on it, but directly, when, you know, we're thinking about the homeless population or people that are precariously housed, what can be implemented to really help them? Like, and it could come down to the core issues. Yeah. Yeah, exactly. Yeah, so that's a good one. So I think that's where Tiffany was going to talk about supportive housing, because that seems to be a good one. And I think one of you talked about what was going down. I think it was you, Catherine, what's going on in tiny houses and the support there. Was it you? Yeah.
Yeah, I did mention that. We have St. Joe's staff, primarily from Womankind, that are going there to support as well. I'll defer like more specifics to Tiffany, but it's a common theme. It's been like this now for as many years as I can recall. House the individual. Okay, you know, there's a sense of community at home and belonging. I also think that, you know, trying to reduce as many barriers to engagement as possible. Drop-in services, drop-in groups, and really, you know, going into the community, doing the outreach and stuff, because working out in Halton and Norfolk for close to 10 years alone, the biggest barrier to actually going to like a doctor's appointment, dentist appointment, was how do I get there? Because it's 10, 15, 20 kilometers away, and the cost of, you know, a subsidized transportation service was still quite costly for individuals. Taxis were just absolutely like, it wasn't manageable for most individuals. So really, you know, trying to be as low barrier as possible so people can actually go and engage in treatment, engage in counseling. I think this, yeah.
Excellent.
If I may, yeah, I can add to that in terms of housing. One of the things that there's a lot of evidence to demonstrate that folks need enhanced supports when they're coming from being unhoused and being housed. You can't just give someone a key to an apartment and say, there you go, and expect them to flourish. We've seen there are some models out there that have worked very well with providing enhanced supports for folks when they're moved into housing. Supportive housing is key to transitioning from being precariously housed or unhoused to being housed. So the supports are critical.
Thanks, Ray.
And sorry, Ray, further to your point, like when we say supports perhaps and the enhanced support, it's really breaking it down to like the basics. Stuff that perhaps we take for granted because we have the skill set to do it. So that local, you know, that daily engagement, daily reminder to perhaps take your medication, go to an appointment and stuff like that. We try to problem solve with like basic tasks and stuff. And I've done it side by side with a lot of patients in their early recovery, whether it was from substance use, mental health, or both. And then seeing the growth where we can take a step back as counselors, like doing side by side life skills, and then, you know, getting the report 5-6 years later, oh, the person's doing really well.
Susan.
So one of the other things I think to add with housing is also looking at income security and food security, because I think what happens a lot of times is, again, people just have the basics for rent, then that's a very difficult place to be. And sometimes then it becomes, I have more community on the street than I do in my housing, and I also can't afford sort of basic stuff. So I think advocacy for housing, income support, and food security is really important.
Thanks for that. So we've heard, it's funny, I'm sure you read the book too, They Call Me Margaret, and her journey was about the mental health and what she went through. And I really listened to what you said, Catherine and Ray, about the supports and the housing first approach. But it's really about those check-ins. How are you doing? Are you taking your meds? Oh, you missed that appointment today. And I think the follow-up question is, do we have that? Who is that person that's following up on these people that are active in treatment? And that's an important one for me to understand. Yeah, I could do it if I was a caregiver, if it was my child, but how does the system approach that currently? I don't know if anybody.
I can give a note. My predecessor, Pete Weisner, is pretty well known in the community. He's very vocal, very kind gentleman. He's since moved on from the program, but he grew the program. And then when you grow a program and you bring other people on to the program to help, then you turn into this very large service. And we found that we were servicing so many people, like to the tune of thousands of individuals in the community. So I think really it comes down to managing resources, and this is where we're at right now. We just wrote for additional grant funding with the CSP grant, and it's about almost narrowing our focus to an extent. And we're not trying to take away service from individuals, but being strategic with the way that we're doing things. And I know Catherine alluded to that. It's about not giving up on people when you do take that step, because it takes more than just giving somebody an apartment. I've seen that. I've been into those apartments. I know that I'm sure you have as well. But there is a difference between someone who's provided with something and left on their own, and someone who's provided something and there's check-ins. There's a very, very large difference there.
Mm-hmm. Do you have anything to add, Catherine, to that?
I think every community is different, because I know like within Hamilton, Indwell, they provide additional support. We have St. Joe's Actings, and also the Homes program, CMHA, and other communities also provide that additional support. Social Nav, EMS provides variations of supports throughout the community and stuff. So it's really community specific.
Mm-hmm. Okay, thanks. So next question. There have been many reports, and you alluded to it, about open drug use on the streets and in parks, etc. I think, we've heard it about encampments, but we've also heard about in alleys on streets, open drug use, just standing there. What do you think we could do as citizens if we're seeing this, being affected by it? What are the next steps for us? What can we be doing?
As citizens, or what the police can be doing?
Well, I think as citizens and what's going on.
Yeah,
what can we do?
Again, like to look through the lens that there's an illness and there's trouble there, there's history with that individual. To not demonize the behavior. I know there's a lot of crude people in this world, and they're going to label that person as this drug user, and then it ends there. That's the period. That's not the period. There's a history that comes with someone that's on the street. I used to park my car in close proximity to the investigative service building, and I'd walk down Mary Street. You can't miss someone openly using on the street, but there is public safety, whether or not it's real and or there's a perceived risk with public safety. And the Hamilton Downtown BIA had run a survey last spring or summer, and over 1,000 people responded. And those were the number 1 and 2, risk factors for them attending the downtown court was open public drug use and encampments or unsheltered persons. And again, there's people that have biases, but that perceived or real risk, and someone committing that criminal offense, out in public, it puts a spin on people's vision of what Hamilton is. Hamilton is more than downtown, I know that, but downtown shapes the entire community. So I think the role of police, namely, and the partners that we work with, is about intervention of when that's happening, interjecting ourselves, and then treating it from a health-centered approach and trying to give them the help that they need.
So me as a citizen, great points. And I liked how you framed that. It's just about perceptions and understanding what the person's going through. But not everybody has that same understanding. But to get intervention, like to get the police there or to get somebody else, if I'm the citizen and I'm afraid, will we call you?
Everyone has the right to call 911 or non-emergency line about criminal activity that they see. And I know that might not be the kindest words to use. It is a criminal offense to openly use opioids in public. The criminal code has not changed, but the way that we treat that criminal offense has drastically changed in the last 4, 5, 6 years, drastically. And that's a good thing. But it's still a criminal offense, so if you do deem it necessary, again, the Public Prosecution Service of Canada talks about degrees of severity when it comes to actually laying a criminal charge and when it accompanies the simple possession of a controlled substance. And one of those degrees of severity is being in a place around children. And so if you see somebody openly using drugs and there's kids within earshot, playing in the water park or trying to enjoy that space, that is a degree of severity where we would consider laying a charge. In the first 100 days of us, this initiative, the RAM referral, we've criminally charged one person in the entire city of Hamilton with possession of a controlled substance. That's the criminal charge. And there was a large quantity of drugs, and it was probably to be considered for possession for the purpose of trafficking. It was a large quantity of fentanyl, but that was the criminal charge that was laid. So in my perspective, it's really zero. But in saying that, if I'm walking by, it's that gut check time as a police officer. We're hired to use our experience, and we should have this degree of morality that when you see someone openly using drugs and there's little kids around, and there's an elementary school, I would hope that you would consider that to be that severe factor that would warrant somebody be criminally charged. But it's not happening yet, and I'm thankful for that.
Right.
If I may, I won't drone on about it, but the on the one hand, the how you respond to that situation is one thing, and that's all well and good. However, I think I'd be remiss if I didn't at least touch on the idea of prevention. That there are measures that we ought to be looking at that prevent that instance of public drug use, and one of those is safe consumption sites, and unfortunately recently we've lost those for political reasons, I think, but as I say, I won't go on about that, but I think that part of the discussion has to be around the prevention side, and housing is a big part of that, in my opinion.
Mm-hmm. Excellent. Thanks, Ray. Really good points. And it's really looking at all of the social determinants of health and how can you deal with anything if you don't have the basics. Okay, now this is a big question because we've heard about some great programs, but what is the wait list right now to start any treatment or recovery program? Like, is there a wait list to get into St. Joe's? Is there a wait list for ADGS? Like, what are you?
It's fair to say like there are wait lists for I think every program. There's a centralized codex that if people are specifically interested in specific treatments, like residential or treatment programs, you can go on there and try to get an up-to-date, like what is the wait time? Because wait times fluctuate so much, and then even calling, We also, like, I know within my portfolio, my programs, we do the best that we can to like prioritize. Like if there's a level of acuity and stuff, we have what's called like priority appointments and stuff that we can try to expedite that. The brain clinic, we try to get individuals in as quickly as possible, usually within 72 hours. Now that does fluctuate depending on if there's a weekend or a staff holiday, and staffing across the board, I think it's fair to say at different agencies that can play a role in it. But we also have our drop-in hours for the RAM clinic every Wednesday morning, so that kind of like offsets that too. So if somebody was really interested, they could access that as well.
Excellent.
I think I would definitely agree with Catherine that a lot of times people do want to know like days, numbers, months, or wait times, and it's very hard sometimes to give that. And it is a huge frustration. It's for people who you finally kind of make the decision, you want some help, and then you call somewhere and it's, hey, even if it's 3 days, 7 days, and family members, we get a lot of calls from family members trying to understand the system that, my family member is ready to go, and now I'm going to wait. And so it's a hard thing, but I would agree with Catherine that it's always, please call, because sometimes wait times will put people off of calling, but quite often we have to have what we call wait list strategies to sort of help if somebody's on a wait list, can we refer you to somewhere else? Is there another program? And we have things in the community like self-help, like Alcoholic Anonymous, which is, you can find a group that night. And so I think it's really on us as treatment providers to say, okay, what can we help you with while you wait for that next step? And I think most of our programs have that in place.
That's great. Thank you. I know even here at Cathedral Cafe, they've got Narcotic Anonymous on Saturdays, which is great. They also have peer support groups, which I heard from you, which is another great model. So it may be a little bit of wait, but in the interim, they could be asking, there is a priority setting to get somebody in, and there's some temporary alternatives to keep the momentum going. Thank you. Now, most of you promote it very much a harm reduction model. So why not total abstinence from drug use? Why do we make that distinction about harm reduction versus, okay.
I suppose I'll grab that one. None of us, I don't think, have said not abstinence. So if abstinence is a choice that someone is motivated to make, if someone has a desire to seek abstinence, then they'll be supported by everyone across the board, I'm sure. From a provider of harm reduction services, I don't exclude people who are interested in abstinence from the work that we do. I see it as one spot on the spectrum of services. So it really is a broad array of services that are being offered, and abstinence is one of those goals that services are available for those folks, and hopefully the wait list isn't too long.
Excellent. Anybody else want to add in?
I think when we talked about addictions, that we have to also recognize that individuals exist along the continuum of substance use. And so for some, immediate absence is not the option that they can do at that time. And so we really need to support them where they are, and respect their decisions in
No, but that, excellent, excellent. Now, do we actually have detox or a residential treatment program here? Because often you hear, so you mentioned that there's MASH, Womankind.
Yes, so we have MASH Residential Services in Hamilton, also known as withdrawal management, formerly known as detox. Throughout the years, the terminology has definitely changed. We also have Womankind as well, so women's withdrawal management, formerly known as detox. At Womankind, we also have a residential program as well, and if people are interested in accessing those services, I would encourage you to continue to call. If the counselor says, call me back at a certain time, please call them back at a certain time. They will do a screening and they'll put you on the wait list. They do reach out and say, okay, we've got a bed available, but also, proactively checking in with any sort of detox or withdrawal management center that you're interested in going to. And also recognizing that we have detox withdrawal management in Toronto, in Simcoe, Kitchener-Waterloo has a withdrawal management center. So also perhaps expanding your options to if that's a possibility. It's not for everyone.
Just one program not put on the table, but we have Wayside, which is an inpatient treatment center for men and also provides supportive housing after the program as well.
Great. Thanks for that. Now, I was trying to save this one when Tiffany was here, but we all talked about the closure of the safe consumption sites. For people that don't know, there was one down on St. Paul's Church down on James Street South. So that was closed, I believe around March 2025. And now is to be the implementation of this new heart model. I'm just wondering, have you seen any direct impacts from the closure and the work that you're doing?
I can say that, as part of public health's role is closely monitoring some of the things that are happening. For some long-term implications, increasing HIV rates or potential increase in Hep C or hepatitis B rates, those are going to be long-term, so we might not see that right away. It's reached out to our community partners. They did provide us some information about overdoses that they've seen in the community. Nothing specific in terms of a drug that's causing it, but it is again something that has been significant because we haven't had a drug alert. This is the first drug alert that we've had in 2025.
Wow.
So yeah, so we are seeing some trends in data. We are carefully monitoring as well, things like invasive group-based strep as well. It could be one of the indications that we might see from people not having wound care that they had at the consumption and treatment site. And so I think there's lots of community agencies that have done mitigation strategies and do have people out there providing things like wound care, our nurses out there testing. Lots of agencies are providing health care out in the community, but the CTS was that central place where people could access that and not use drugs from the public, right? So.
Great.
Yeah, there's a little harder to measure, you know, is the disenfranchisement that has happened with that among that community that frequented the safe consumption site. Some of those folks are now disconnected where they felt connection before. You know, that doesn't account for directly, like Sherilyn said, with statistics, but anecdotally we can see that there are some people that are now feeling disconnected where they previously felt connected, and I think that you know, it's worth saying that the Heart Hub model in our case here in Hamilton, the MHAT, is there's no reason in my mind why we can't have that and a safe consumption sites. So, you know, I don't think it really necessarily needs to be an either-or proposition, which is kind of how it's been presented. But so, you know, I think that we should remain open to those discussions around safe consumption sites coming back. It's worth noting that the #1 cause of mortality of the substance was alcohol, and we have many safe consumption sites in the city for alcohol consumption. So, you know, just making a point there. Thanks.
Appreciate that, Ray. I do have a last question, but I think it's really important that we hear from you guys. If you have a question for our panel or a few questions, please, I think the mic in the middle is ready to go. Is it on, Turner? I think. Yeah, ready to go. Okay.
I just spent the last couple of minutes looking up what harm reduction really means, because it's used easily with you because you deal with it all the time. The only thing that I found that was clear to me was supplies, needles, naloxone kits, etc. Condoms, I'm not sure what else. But what is harm reduction? I mean, abstinence is going into a facility for the most part. Everyone's providing these services, but I don't really have a crystal clear idea of what they are.
Sure, if I may, there was I touched on this earlier, but I probably breezed over it, and this is a definition that I brought with me. Harm reduction is an evidence-based, client-centered approach. I'm sorry?
Sorry, that's gobbledygook to me.
Oh, okay. So let me elaborate then. Okay. So what I mean by those things is that by client-centered, it means that our approaches are meant to be centered around the individual needs of people, of human beings. And so what we try to do is meet them literally where they're at and meet their needs wherever they are on the continuum of addictions or substance use. So we'll provide them with information and education and safe practices, what we know to be safe practices, and provide some of those things that you talked about, syringes, condoms, those things are part of that, but efforts to reduce the harm that is associated, whatever harm is associated with, in this case, substance use, that's what a harm reduction approach is. We know that we can't necessarily change the behavior of the individual, but maybe we can have an impact by providing them with safer alternatives. Does that help? Anyone else want to?
I think too, and this is just a comment, I just had a conversation with Margo, one of my nurses today, about this. I think that sometimes when you hear the term harm reduction, you automatically think substance use. Harm reduction is not new. It is things, different practices, different policies, different things that are put in place in order to protect people when they're doing inherently, you know, what could be a risky thing. So, for example, we always go back to driving a car. Driving a car is incredibly dangerous, especially if you drive fast. Put into place for policies around seatbelt use. Everyone now needs to wear a seatbelt. Car seats for infants. Those are all harm reduction strategies to reduce the risk associated with what is considered a dangerous activity. Does that help?
Okay. Are we okay, Roseanne? Does that help? Okay. We'll go on to the next question, please.
This is for Susan Boyd. You mentioned availability and access and contributing factors to addiction, and then you said you've seen an increase in access due to recent changes. Can you speak to those recent changes?
So this one would be sort of more specifically looking at recent changes around cannabis and then also around alcohol, and that we do now have our access to alcohol was put into sort of corner stores. I'm trying to think what the other locations were.
Grocery stores, gas stations, yeah.
Sort of expanding. So what happens is as you get a higher saturation of like availability, that can impact your what we call prevalence of substance use concerns. And same thing when cannabis was legalized, and then we have more shops around and available. It just again, it's the access. It doesn't mean there will be like people will become addicted, but it just gives that opportunity.
Okay.
And you know, again, and people would also say there are benefits, and that you have sort of a higher quality supply, not as it's dangerous to go out around cannabis, but not necessarily the same for alcohol. Does that help?
That helps. Thank you very much.
Thank you. Thanks, Susan. Next question.
My question comes out of statistics that you presented, Sherilyn. The statistic was that Hamilton is above the norm in terms of opioid deaths. I read The Spectator as well, and I see that, you know, we don't do well in Hamilton in terms of our encampments and other indices of social unwell-being in this city. So I'd like to know if you have any researched facts you can present us, or if there aren't any researched facts, whether you have any theories as to why Hamilton is doing worse than our peers within this province. And building on that, is there anything that our city council could have done or could be doing now, or our police force or any other agencies within our municipality that could have made us do better and could now make us do better? Well, I'm inviting speculation. I'm inviting theories as to why this is happening. And all of you sitting there are in an excellent position to theorize because you're dealing with this population. Those of us who don't have direct well, I have some direct. I work at the cafe, you know, I walk on the city streets, but I don't have that career experience that you have. So you're in an ideal position to offer educated theories as to why we're worse off in this city.
We have an opinion here.
We know based on the Code Red series that came out like a long time ago now, that the social determinants of health, which is factors that we can and can't control that make us who we are and that affect our lives, it determines like the impact that and the kind of health conditions that we'll have. So we know from the Code Red series that Hamilton, especially downtown core and in different pockets, it was sorted by postal codes. We were able to look up our postal code and see what our stats were. Is disproportionately affected by poverty. We have folks that just have high needs. So when you're impacted by things like having a different ethnicity, if you're female, if you're older adult versus like 18 to like 40, many different factors. If you have a mental health concern, violence in the family, all of those kinds of things, it will affect employment. That's right. That's right. She can get the rest of them, actually. Do you want to jump in? Yeah.
We can tag team.
Yeah.
Because I do remember that series, but like your employment, your education, whether or not you have a partner, like access to like medical care, appropriate medical care, and the stuff that you actually needed, able to access. So you had to go to town with regards to like a specialty appointment. Do you have the means to attend that appointment? Drug coverage, adherence to like treatment for a medical condition, our economical state too, because unfortunately been industries that have fluctuated quite a bit, and those are good paying jobs that unfortunately are no longer here in the community. The cost of housing, I think, is like tripled, if not quadrupled, even within the last 10 years. I know that Carrie and I also had a conversation. Invited me to this, and it's a very complex answer, and there's no one, like there's not going to be one solution for this, unfortunately.
The one thing that I'll add is I remember, as being a 21-year-old wet behind the ears, starting my career policing, you had these senior officers talking about kind of this chicken and egg scenario, and that Hamilton has always been one to provide a lot of resources in the community for reasons of mental health. So was there this immigration of those that required the help? And do we have settlers of those that suffer from mental illness? And then,
And
I don't know if that's an ignorant view or not.
Well,
it's a dated one, I'm sure.
With regards to like the resources and stuff like this is going back to 2013, 2014. I had a one-bedroom, nice apartment here in Hamilton, underground parking, that was $735. Fast forward now, I think that apartment is going for close to $1,900, and it is what it is. Like, just to put that in perspective, just the cost of living, when I think about it for myself and stuff like that, and then I also think about my colleagues too, being younger and starting off in the city with a job and so forth. I also look back, 20 years ago in the city, we had an abundance of transitional beds specifically for men. Jamesville down on James Street here, and then also like shorter wait times to get into treatment. And I think that there is an increasing need, substantial need for this community. And I don't think our resources necessarily have kept up with the pace for various reasons. And the influx of newcomers to Hamilton. When I say newcomers, whether it's from Toronto, Kitchener, surrounding areas. It's grown substantially.
And court decisions have shaped our response. We've had encampment protocols for some time, and they were lifted in the spring, and it's all correlated with shelter space. So when the city deems that there's enough shelter space, that's when there's more of that intervention by our bylaw services, police, city parks. So like when you go so long with not interjecting, of course there's going to be that offer for shelter space, but when we lawfully we're not moving anyone in a tent, does that behavior perpetuate itself in the community? Do people come from outside town knowing that they're able to live like that? And we saw a rise over the years of people immigrating to Hamilton to do just that. So then now does the problem get bigger? I think we saw it get bigger.
But what did other cities do about that? Why did Hamilton get this reputation for being the place to move to?
Well, again, I talked about the availability of shelter space. We were in this unique position where we didn't have this shelter space. But if you go down the 403 to our west in Brantford, they had the shelter space so that when they did intervene and that someone was setting up a tent in the park, they'd say, this isn't an acceptable behavior, we want to give you housing or short-term housing and we're going to work with you in that full circle of care. We could provide those types of full circle of care, but if the person in Hamilton chose to live in a tent, they had the liberty to do so up until this past spring.
But they didn't have in Brantford?
Not in Brantford, they had available shelter space, so it wasn't tolerant. There wasn't a protocol in place.
I think all great points, and I could say, you know, I think about that code red, and I also think about a basic income, and I think about Thunder Bay and the numbers. I think about the history of Hamilton and the even economic changes or the factors that drive employment. And yes, they're diversifying, you know, what work is available, but I also think there was a lot of people left behind when jobs were lost. And combined with housing, I think all of these factors, which comes down to, there's not an easy answer, but this is why we wanted to talk about it. What could we do? Sorry, I'll go on. Next question.
This is going to be mostly on Jim, but because you've said that safe injection sites, safe use sites are gone now, right? So then we're talking about the people who are using drugs on the streets, and you said quite clearly, unless I got it wrong, that that's a criminal offense. So, okay, no, I work at the Cathedral Cafe, and I work with individuals. So you've got individuals on the street that are using or mixing or heating, whatever they're doing. What tangibly happens? Does someone have to report them, or do you go, or did the police turn up, or do the paramedics turn up? Are they charged? Are they taken off the street and puts? What tangibly, Jim, happens?
For the most part, it organically happens, like proactively, and officers driving by and they observe something. So
Yeah, and what does the proactive mean?
proactive means they could be doing anything in the community. They could be going to a call for service, they could be patrolling their beat. They're just active in the community, they're working in a uniform capacity.
Okay, so does someone have to basically blow the whistle on the individuals that are using on the street?
No.
Okay, so it's up to you guys
Oh, yes.
to see it, or to be, do we call 911?
You can, yes.
Okay.
We can respond to calls for service.
And then the police car turns up where these people are using,
Yes.
and then what happens to them?
That person can be arrested for a criminal offense. That is in the power of the officer.
And charged and taken off the street?
No, not charged. So there's going to be degrees of severity that they can consider, but the direction from the Hamilton Police Service and the Public Prosecution Service of Canada is to not charge that individual, to not put them in the court system, to not criminally charge them. So liberties can be taken away. Someone can be detained or arrested. They're afforded their right to counsel and caution for a criminal offense.
And are they referred or taken anywhere?
Our efforts, our primary efforts, is to A, make sure that they're okay, and B, offer them a referral service to the RAM. That is what we're telling our officers. That is the primary motivation when you see a uniformed officer intervening in public drug use.
Okay, and so is it therefore necessary that these individuals recognize, I have a problem? I mean, there's no coercion, right, to get help?
No, it's not. It's not
Exactly.
any type of diversion.
Yeah.
It's completely on. We provide the referral.
Okay.
There's no compulsion. Like we can't, and we are not compelling them to go.
Okay.
There is no quid pro quo. There's not. If you don't go, you are going to get criminally
Yeah, I just
charged.
wanted, because, I mean, there are no safe injection sites, so where is someone who is addicted going to go? Because their body craves something, so they have to do something, and they're not housed, so inside a doorway or down an alley works. It doesn't work, it's just, that's it, there is no option.
I don't think there's an easy answer for that. I don't think we can give a satisfactory answer to that question.
Mhm. And that was really a learning for me, is hearing from Dave about what the police are doing. Because it's just like begging on the street. Does it really make sense to give somebody a fine, take them to jail, when they don't have money or anything to begin with?
Well, they have a roof over their head and food.
Well, something. But what I heard clearly is this is, first of all, making sure they're okay, and it's not a trafficking situation. And as Sergeant Jim identified to us, there's been one situation when the person was charged with trafficking, so having a large supply of drugs on them, correct? That's what I heard? What?
So there was one charge laid in the first 100 days of the initiative. We're getting back to the focus on this.
Yeah.
And that was just for possession-related, possession-related charge, just Section 4.1 of the CDSA.
Yeah.
What was alarming, actually, was that a quarter of our drug trafficking charges for possession for the purpose of trafficking, a quarter of the entire city's, it's Section 5 sub 2 of the CDSA, a quarter of the city's possession for the purpose of trafficking charges stemmed from police intervening in open public drug use, which was alarming. Again, in my work history and being here for the last 16 years and the type of police work I've done, historically that has never been the case. And I've said that to some of the panel members here. I'm actually shocked by it, to the tune of over almost a half kilogram of fentanyl has been seized from individuals, and there was 14 persons charged for possession for the purpose of trafficking. Out of over 250 incidents of police officers intervening in open public drug use. It's alarming.
Well, my other point was that you get someone who comes and they get, say, with Catherine's programs or, with MAD or whatever, and they're taken off and they're trying to deal with their problem, right? So they're off the street, they're in a place that is safe, that is conducive, and then they're released. And when they're released, they're going to go back probably to the same patterns of living, the same friends they had before, and that's just like zoot back down the rabbit hole. If there's no really well thought out support services, for people coming out of treatment. Sorry, go ahead, Tiffany.
You actually bring up a really good point there, so thank you for that. So the transitional piece, when I was speaking earlier about the MAT Hub services, I completely forgot two of the other big services that we have, and I was just narrowly focusing on one. So when people come out of treatment, when people come out of being incarcerated, what are the supports that are in place so that the folks that weren't using for a period of time don't fall back into old habits, and so that we're not testing those coping strategies quite so hard and easing them back into life. So we do have a residential care treatment facility that's coming up. We're looking at by fall 2025, and so that is a program that is not only intensive addiction services, which is also available at Womankind. They have the intensive addiction program. I think we also have at MASH, we have the addiction program as well. The only difference is we don't have withdrawal management, which means that people would have to go to detox elsewhere and then come to us, but we work with our partners and we're on plenty of meetings arranging those pathways. So anyhow, intensive addiction treatment for 6 weeks, then followed by transitional and supportive housing phases, so that these folks that have come to us and that have done all of that hard work to get well are now not getting released back onto the street and then having to repeat the process, because we know that many people that wind up being unhoused end up also using substances as a result of trying to keep themselves safe while they're on the street, knowing that they may be assaulted or be victims of crime if they fall asleep, so then they start using stimulants to stay awake. And you'll find that they'll be sleeping in public spaces like the library because they feel safe during the day to sleep there, and they can't sleep at night. I'm seeing a lot of head nods, so I know that this isn't news to anyone. So yes, transitional supportive housing is so important. Building more of it. We know that we need affordable housing. So like the panel members are saying, it's a multi-pronged approach. It's not one solution, not more shelter space alone will fix the fact that there's not enough shelter space. It's how many people would be more appropriate in a supportive housing, how many people need to be in treatment. So yeah, there is no answer. Thank you.
I think I just wanted to add one thing to that as
Oh.
well, just when we're coming out of treatment and out of places like corrections and where you have been abstinent for a period of time. Like Susan talked about, sometimes can be quite a cycle where people relapse and go back and forth. But that is an incredibly dangerous time for persons with opioid addictions because their tolerance to that substance drops significantly during that abstinence period. And so it's really important that there is supports and services and things like naloxone available for those individuals should they relapse because they are at really high risk. We see that definitely in stats and data where people, particularly coming out of corrections, are at a really, really high risk.
Thank you. Next question.
Hey, so my question is basically for the whole panel. I work across the street, and I'm here to kind of listen in that capacity, but I'm going to kind of speak just as an individual. I'm a left-wing activist in my off hours, and one of the things that, like we've talked a lot about the social determinants of health and how that dramatically impacts not just things like addiction rates and also, I don't want to use the term recidivism because that implies like a criminality. That's not what I'm getting at, but like repeated falling into those old habits. One of the things that an old ally of mine, former MPP Sarah Jammett, taught me was that this Hamilton Centre is, I believe she said it was the poorest riding in all of Ontario, if I'm not mistaken, and up there with all of Canada, which is pretty severe. And when I look at that, I look to the province as well. Like I really look at the province and how it's nothing, like everyone on this panel is working all the time. Everyone at the cafe working all the time to try to help do what they can. But what I see is like strong, dedicated staff working in so many different angles, trying to bail out something of a sinking ship. And the thing that's needed is the Coast Guard to come out. When I look at the way that Doug Ford, and I'm interested in hearing everyone's commentary, anybody who'd like to comment, but I've heard some very professional takes on it and talking about like how we're transitioning as a province from one where we can look at harm reduction, which is excellent. I'm personally in favor of harm reduction in various ways, whether it's drugs or what have you. To an abstinence only thing, which typically when you hear a term like abstinence only, it's I hear ineffective, like something that doesn't work, something that doesn't lead to abstinence, something that doesn't lead to good treatment outcomes, something that is usually promoted by people that are ignorant of the actual results of their actions. So Doug Ford, when I last checked, he was sitting on hundreds of millions of dollars that was earmarked by former PM Justin Trudeau. This is how far it goes back.
Yeah, so there's a question in here.
Basically, my question is how much of this goes back to the province? And what needs to be done to basically shake them down? I'm just going to put a fine point on it. Because I don't, like, I've obviously voiced my opinion, but what do you guys think? Like, that's what I want to know. Like, what do we do about this?
Thank you. Does anybody want to take a stab? I will say, healthcare falls under the province. Income support is both provincial and federal, and housing. So it's got to be both a federal and a provincial change. Like I've heard clearly today about income and housing, and we know that. This is the first thing that came out recently when we talked. We need, even when we were forming Cathedral Cafe, when we talked to, did a survey with neighbors and services. What is the number one need in our neighborhood? And we're talking 5 years ago. Number one issue, housing. No surprise. Number two, a safe space for people to come. So housing is still our number one issue. You can't look elsewhere to figure that out. Supportive housing we need. So I'm not going to hold it up. Is there any other suggestions? Because I think this is an action we could take as citizens is if we're seeing that we need rates increased, a basic income, you know, things addressed like housing, we have to use our voices with our elected officials, both provincially and federally. Sorry, Ray?
Yeah, no, that's okay. Just one quick point from just a personal opinion. I think that sometimes the money that gets spent on housing in general, there's federal funds that are being applied to try and address housing concerns. I think there's a tendency to create more sort of middle-class housing as opposed to affordable housing.
Absolutely.
Rather than spending, you know, these government funds on housing for people that can afford it, let's focus on affordable housing. You know, that would be my take.
Completely agreed.
Thank you for the question. I'm really conscious of time. Now, you're a second time, and then we'll get you to ask your question, and then we're going to have to close it down because our guests have been here longer than anticipated, and I thank you for that. Go ahead. Thank you.
Good afternoon. My name's Dan Miles. I live around the corner at 218 McNabb and Colburn. I have a site on Instagram called Intervention Intersection. All my camera uploads, like this morning, I started at 6:16 this morning when the man overdosed on my lawn. That's how my day began this morning. And he successfully was revived by himself, and basically all I had to do was hand him a cold can of Coca-Cola and up he jumped. So that was the morning, right? But do you guys live in this neighborhood at all? Any of you? You do? Okay. Not right here, but pretty close? Okay, that's good. But you're aware then of all the theft that we're suffering here at night and all that kind of stuff? I've had 3 homicides on my cameras, and my neighbors are literally terrified by what's going on. I have the equivalent of Portuguese Ned Flanders that has gone out and bought a shotgun next to me because he's scared, right? So, and when I look at policing, you're horribly understaffed. Like, you don't have the resources that you need to help. And these guys behind me here, these paramedics, they are our heroes in the night, literally. I see these guys running day and night, right? But I feel that our Ward 2 councillor, who doesn't seem to be present here.
He couldn't be here today. He sent regrets.
Regrets don't help. What we need is this guy to have interaction with the police. Stop saying defund the police, okay? Stop saying I won't interact with them, and have more communication amongst ourselves. I believe that's a crucial point. Do you agree with that? Is that plausible?
I love communication.
There you go. Excellent. Well, hopefully we'll be doing a lot more of it because I'm running for Ward 2 councillor next year. So I'm hoping to see you all.
Good luck.
Thank you.
Well, thank you for that. And I think at this point we're going to end it. I want to first of all go through some closing here. I honestly believe, and please tell me, stand up if you disagree, our objectives for this session was met. You know, we found out what was going on in the city, clearly. We know now about addictions. I think some of the actions that we want to take are exactly what we've already talked about on a personal level. How can we change our language or interactions with people and understanding and meeting them where they are? And as an individual, do you carry an naloxone? Is that available to you just in case these scenarios come up? Understanding what the police are doing and what services are out there and advocating for people that way. On a systems level, I think what we've heard clearly is to try and work on addictions. It's a housing first approach. So how are we advocating for more housing? How are we encouraging this? And it's not just bricks and mortars. It's the services that goes with it. And your last comment about police. You know, we're hearing that everybody along this row is collaborating. Oh, sorry. Do you want to go to the microphone? Sorry.
I just appreciate being able to have a minute to say something. I've invested in the downtown core to provide affordable housing for people. And over the long weekend, I was broken into 4 times. I had video of him. We got his name. We tracked it down because of the community. And largely because of Dan. My team that was working at my property lost thousands and thousands of dollars in their tools that they worked their tails off to put food on their table. This man came into my home 4 times. I had video of him casually, comfortably going through my stuff, my child's stuff. I reported him. He was to be charged. You know what I was told? He's going to get a talking to. He is going to get a talking to. What good is it for me to come put my savings that I've worked for 7 years to put into a downtown core for affordable housing when my child and potential other people that I would like to feel they're safe, what do I do?
We can talk after this, okay?
Thank you, Jim.
I understand how it feels to be victimized. I too have been victimized.
Absolutely.
I deal with victims on a regular basis. I understand the way you're feeling. We'll have a
Okay, but I also say a stern talking to, it meant like, it sounded like my house was egged, like a 10-year-old. And that was the response.
Okay, we're going to take that offline, but I think there are resources. We are looking at it. And I will say, and I could only assume, not everything could be explained on what the outcomes are going to be. There's some confidentiality, but we'll get to yours. And that's valid. We want to have answers here. So thank you for bringing your concern forward. So we've talked about actions. So I know our information booths are going to be closing, you know, if they could stay for a couple of minutes. So anybody that hasn't visited them can check them out. I want to thank everybody back there for being available. You're just amazing. So again, we got St. Matthew's, St. Matt's now that they're called, and we have Positive Health Network over there. We have public health nurses, harm reduction. We've got our paramedics that are doing a lot on the street. Behind them is Metis Nation, working with Indigenous folks. Please visit them. We have Canadian Mental Health, amazing. We have Urban Core, is that over there? Did I miss somebody? Because I know we had 7. Okay, well, thank you for being here, appreciate it. Also, thank you. Can we give a hand to the panel? I gotta say, as a community, they're amazing. They said yes. Now, I had to hound them for a while because everybody's busy, honestly, but they said yes because they want to be here. They want to be part of a solution. They live in this community too. We all want to be a part of a solution. So I thank you for that. Not everybody's going to say yes, but you're not afraid of these hard conversations because it's hard work you do. So thank you. And I want to thank the Community Engagement Committee. Roseanne and Nancy were at refreshments, and we had Inez, Michael, Tom, David, who else am I missing? But they were helping to be greeters, of course, Turner for the sound system and for taping, and of course, all of you for being here. Thank you so much for your interest. I think we kind of know what our next topic is. And it has to do with income, I think, but that will be discussed later. But please walk away from here with some information and take some action. A phone call to your MP, MPP, thinking about others. So thank you. Thank you. Oh. Yeah. Thank you.